The emergency's over. The TPA's been given, or it wasn't. The thrombectomy was done, or maybe the patient didn't qualify. Either way, now we shift from saving the brain to protecting what's left of it. This is where secondary prevention takes the spotlight. First up, medications. Almost every stroke patient leaves the hospital with some sort of antiplatelet or anticoagulant, and sometimes both, at least for a little while. If the stroke was non-cardioembolic, meaning it wasn't caused by atrial fibrillation or some other heart-related issue, we typically use antiplatelet therapy. That might mean aspirin alone, or in some cases a combo, aspirin plus clopidogrel, called dual antiplatelet therapy, or DAT, used short-term, usually for 21 to 90 days, especially after a minor stroke or TIA. Another option is aspirin combined with extended-release dipyridamole, which you'll sometimes see used for long-term prevention. Now, if the stroke was due to atrial fibrillation or another cardioembolic cause, we pivot to anticoagulants. Warfarin, with an INR goal of 2 to 3, or one of the DOACs, like apixaban, rivaroxaban, dabigatran, or edoxaban. If a patient can't tolerate anticoagulants, maybe they're high risk for bleeding, we fall back to aspirin alone, but that's a second-choice option. Regardless of cause, statins are almost always started, even if the patient's LDL isn't technically high. This is about plaque stabilization, not just cholesterol. Atorvastatin and simvastatin are the go-to drugs. They've been shown to reduce both stroke recurrence and overall cardiovascular events. We also tighten up blood pressure control, especially once the acute phase is over. We're talking ACE inhibitors, thiazide diuretics, or a combination. If they're already on something, now's the time to adjust it and make sure they hit those long-term BP targets. Monitoring doesn't stop after the infusion. Post-tPA care comes with its own rules. No aspirin, no anticoagulants for 24 hours. You're checking for bleeding. Gums, IV sites, stool, urine, any NG tubes. Watch for neurologic changes. Could be a sign of hemorrhagic conversion. Keep a tight eye on BP, glucose, and temperature. In the ICU, vitals are done every 15 minutes for the first 2 hours, then every 30 minutes for 6 hours, then hourly for the rest of the 24. That's the rhythm, and there's no skipping steps. Next, we go after the modifiable risk factors, the things that brought the patient here in the first place. Hypertension. Number one cause of stroke, and often the most ignored. Blood sugar control, especially for diabetic patients. Smoking cessation. Every patient should leave with a plan or referral. Diet. Think low sodium, maybe DASH diet or Mediterranean if you're fancy. Exercise with clearance. We're not pushing marathons, just movement. Alcohol in moderation. And sleep apnea, a major, often missed contributor. If they snore or gasp at night, get a sleep study. Let's talk surgical options. If imaging shows significant carotid stenosis, usually 70% or more, and they've had symptoms, we might refer for a carotid endarterectomy, or CEA. That's a surgical removal of plaque from the carotid artery. It's high reward, but not risk-free. Think bleeding, stroke, cranial nerve damage. If the patient isn't a good surgical candidate, maybe they're older or frail, we consider carotid artery stenting instead. It's less invasive, but comes with a slightly higher risk of stroke post-procedure. And what if the patient didn't get TPA? That happens more often than you'd think. Maybe they arrived too late. Maybe their blood pressure was too high. Maybe there was a bleeding risk. For those patients, non-TPA management is still aggressive. We consider endovascular thrombectomy if they qualify. We manage blood pressure carefully, not too high, not too low. Oxygenation and glucose control are crucial. Sometimes we use mannitol or other hyperosmotic agents if there's brain swelling, and we keep a close watch on intracranial pressure affliction. But most importantly, we shift the focus towards supportive care and rehabilitation. That means physical therapy, speech therapy, occupational therapy, and making sure the family understands this is a marathon, not a sprint. Secondary prevention isn't one size fits all. It's personalized, layered, and ongoing. And every piece of it, every aspirin, every statin, every bedtime CPAP machine is another shot at keeping a bad day from becoming a repeat performance.